afternoon and a warm welcome to all of you joining us for our prostate cancer research tour. London is a world leader in prostate cancer imaging and research. Each year, 1 in 9 men are diagnosed with prostate cancer, making this research and new treatment options more important than ever. My name is Pam Taylor, and together with my colleagues and our distinguished lineup of clinicians and researchers, we will be taking you behind the scenes to share some of this innovative and groundbreaking research happening right here in our own backyard. A few notes about today's tour. First, everybody is muted to protect the sound during the presentations. Second, we will be doing a question and answer session at the end of all of the presentations today. So at any time during these various presentations, if you have a question, please feel free to go down to the bottom of your screen and put your question into the chat box, and we will do our best to answer all of them at the end of today's tour. We're going to begin this afternoon with Dr. Glenn Bauman. Dr. Bauman is a radiation oncologist at London Health Sciences Center, a professor in the Department of Oncology at Western University, and a Lawson scientist. Dr. Bauman has a research interest in novel imaging for prostate cancer and precision radiotherapy treatments. Dr. Bauman is coming to us from his office, and he will be sharing the ARGOS trial of PSMA PET MRI-guided radiotherapy.
Thanks, Pam. I'll just share my screen here, and hopefully everybody can see my first slide. Would like to talk a little bit about some of the advances in molecular imaging that we are working on as part of our prostate cancer research here. And it's just as background, prostate cancer is the most common cancer in men, with representing approximately 20% of cancer in men in Canada, and about 10% of cancer deaths in men. The prostate itself is a small gland that's located below the bladder and in front of the rectum. So it presents its challenges in both detecting and treating prostate cancer. And this is some of these challenges we're trying to address with our advances in imaging and treatment. To date, we've relied a lot on a blood test called prostate-specific antigen, PSA, which in general can help in the detection of prostate cancer and the monitoring of treatment of prostate cancer. And in general, as PSA levels go up, that tends to track with the level of disease, whether it's confined just to the prostate, whether it's spread beyond the prostate, say to lymph nodes in the pelvis, or to varying degrees throughout the body. And this, coupled with other information like biopsies of the prostate to tell us the aggressiveness of the cancer, can help us decide whether men might be suitable for just observation. So in the earliest stages of prostate cancer with slow-growing cancers, or whether they might be good candidates for surgery or radiation, or if the cancer is more advanced, integrating drug treatments. And we supplement this clinical assessments and blood tests with imaging, and our imaging techniques to date have largely been based on a nuclear medicine test called a bone scan, which involves injecting a small amount of a radioactive material called technetium, and it tends to home in on areas of the bone where there's active inflammation or bone turnover, and the presence of cancer can definitely stimulate that inflammation in bone. So you can see here an example of a bone scan of a man with prostate cancer, where there's these dark spots represent where that radioactive tracer is going, and represent areas where the bone is involved with cancer. We also have CT scans, which give us cross-sectional images of the body. So this is a slice through the abdomen, and you can see the abdominal, the outside of the person here. You see the abdominal contents, the bowel and such. You can see blood vessels, but importantly, we can see lymph nodes in the body as well. And lymph nodes can be a route of spread for cancers, including prostate cancer. And if we see enlarged lymph nodes on CT scan, that makes us suspicious that they might be involved with cancer. One of the specific challenges that we faced in treating men with prostate cancer is we treat men up front with surgery or radiation or combinations, and then we monitor them, or monitor the success of the treatment with the PSA blood test. And part of the challenge is that this blood test is very sensitive for picking up the presence of prostate cancer, but it doesn't give us information about where the cancer might be active if we start to see the PSA going up. So this is just an example of this. So this was a 56-year-old man who had surgery for prostate cancer. And with that type of treatment, the PSA really over time should be 0. So this red line should not go up. But what we saw in this man was over time, and this is over several years, the PSA slowly climbing. And the value here of 0.25, this is a very low level of PSA, but the trend is upwards, so it makes one suspicious that there is some prostate cancer active in the body. And then what we have been using to date have been our bone scan and CAT scans, but at that low level of PSA, these tests are uninformative. They don't typically show us where the prostate cancer problem is. So then it's hard to know how best to treat that man. Could they benefit from more focused treatment with additional radiation, for example, or do they require drug treatment, or would we be able to just monitor them? And so as we've tried to adjust that challenge in understanding where prostate cancer is to help guide treatment, we've been developed a program looking at advanced imaging to help us do that. And to a large degree, our research has really started to focus in on the use of molecular imaging with a technology called positron emission tomography, or PET scanning. So the premise here is that if you can design a chemical which will attach itself to cancer cells when injected into the body, you can tag that chemical with a radioactive atom and then pick up where in the body it goes after you've injected it. And in this case, we've been working with chemicals or small molecules that attach themselves to something called prostate-specific membrane antigen, which is a type of transporter that's located in the cell membranes of prostate cancer cells. And while it's not truly specific for prostate cancer, there are other tissues that will have these receptors. Prostate cancer definitely overexpresses these receptors, particularly more aggressive prostate cancer or higher volumes of prostate cancer. And we can design specific molecules to bind to this transporter. And the one we use is called DCFPYL. And when we inject this into the body, we have a machine here called a PET CT, which acquires images of where this tracer goes in the body, along with CT scan-like images to help us better understand where the tracer's localizing. And this is an example of the PET component of the PET scan, and you can see where the tracer goes naturally in the body. So naturally, it'll concentrate in some glandular tissue like the salivary glands and the lacrimal glands, in the liver and the bowel and the spleen, in the bladder. But one can see here, these spots here are not normal organs. These are lymph nodes lighting up with the tracer and suggesting that they contain prostate cancer. And here's some further examples of this type of PET scanning combined in this case with an MRI scan. So here we can see the prostate itself. In the front here would be the pubic bone, back here is the rectum. And then this bright spot is where the cancer in the prostate is lighting up, and it can really help identify where the cancer is within the prostate, which can be challenging on other types of imaging like MRI and CT scan. In this case, we have a PET CT, so this is a side view, so you can see the tailbone down here and the spine. This is the liver, bladder that naturally light up. But again, these areas represent lymph nodes. in the abdomen involved with prostate cancer. And here's an example of uptake in a bone of the spine, in a vertebrae, with a single spot of cancer. So in this case, because we only saw one spot of cancer, we treated it with highly focused radiation with the goal of trying to avoid having to use drug treatment in this man. And we've helped lead the development and also the deployment of this type of PSMA PET scanning across locally, but also across Ontario. So we help lead a large provincial registry study, which provides access to this type of PET scanning where it was not available as of about 5 years ago. It's in the last 5 years when we were able to establish this registry, which is funded through Cancer Care Ontario. But we're also using this registry trial as an opportunity to learn more about this PET scan. And we see in analyzing the results, we can see that when we look at men who have been imaged because of concerns about recurrent cancer in a few in different scenarios, either after primary treatment or after different steps along the way in their treatment, we can see overall where we would have struggled to find cancer with our regular bone scans and CAT scans, and about 2/3 of men were picking up sites of cancer. And in many of these men, there are limited sites of cancer that could be treated with targeted treatments as opposed to just putting all men on drug treatment. And we've learned things like the higher the PSA is at the time of our imaging, the more likely the imaging is going to show us where the cancer is. So this has been valuable information for us and learning how this scan helps men. And now we're starting to move the use of this PET scanning up further and in the treatment of men from the recurrent setting now into the primary treatment. And this is where our ARGOS trial comes into play, and the acronym standing for PSMA-guided stereotactic radiotherapy. And then this CLIMBER component is actually an extension of the trial where we do PET scans over time after treatment to understand how do these PET scans change in response to treatment. And if you're a fan of old movies, you might recognize this old fantasy movie, Jason and the Argonauts, and of course, that's ARGOS, and then of course King Kong is our CLIMBER. And this premise is based on research by ourselves and other groups that suggests that if we're designing radiation treatments to treat the prostate, we can give higher doses safely while protecting normal organs like the rectum and the prostate by focusing more radiation at sites in the prostate where we're confident the cancer is. So as opposed to treating the whole gland to a single dose of radiation, if we give the whole gland a moderate dose of radiation and then focus the high dose of radiation in a smaller part of the gland, then we can start to really treat where the cancer problem is. And we see that, at least when we model this in the computer, a probability of getting a cure of the cancer without injuring organs goes up compared to our standard treatments. So that's all well and good when you model this in a computer, but it's important to then validate that through clinical studies and in men. So again, in our ARGOS trial at the front end, we're really looking at the safety and side effects of this type of treatment, where we give the targeted boost based on a combination of PET scan and MRI scan. And then the CLIMBER component is then following these men over time, both for the toxicity, but also how well we're controlling the cancer. And we're also collecting biospecimens like blood tests, and also doing repeat PET scanning over time to see how these changes evolve after our treatment, particularly on the PET scanning, but also are there some other blood markers that might track what we find on the PET scan and could be a surrogate for the PET scan results. And this is just an example of a man being treated on CLIMBER. So the green volume here, this is again a slice through the upper pelvis, and this green volume shows that we're treating the lymph nodes. So we're basically trying to spare bowel and uninvolved structures, but concentrate the radiation on the lymph nodes. And then this is a front view. So here are the hips on either side and the prostate's down here below the bladder. And we're concentrating extra dose of radiation in the prostate itself. And then a side view, again, you can see the bladder, the rectum, there's the tailbone, and you can see how we're treating the lymph nodes to a moderate dose, and then the prostate to somewhat higher dose, and then concentrating the full dose of radiation within the prostate to the area where we've identified it on PET scan and MRI. And then this is just an example of how we do that. You can see on the PET scan part, you can see this bright area is where the cancer is lighting up and where we've concentrated the radiation dose. And you can see this is the matching MRI picture showing, again, where the radiation dose is being concentrated in the prostate. This is not the only study we have underway. We have another study called Patron, which the first study, Argos, was funded by the Ontario Institute for Cancer Research. This one is funded by the Canadian Cancer Society. And this is asking another equally important question, that is, when you use these PET scans to guide treatment, do men do better overall than if you plan them according to your usual standard of care? So this is a study being done Canada-wide that flips a coin, and half the men get a PET scan and treatment based on their PET scan, and half the men get treated according to the current standard of care. And so we are participating in that study as well. And that will give us valuable information about the impact of this PET scanning on men's outcome after primary treatment with radiation or surgery. And that this is just another example, this time of a man being treated on this Patron trial. In this case, you can see front view again, prostate getting more dose concentrated in the area where the PET scan's hot in the prostate. But here we see a lymph node lighting up, and we're able to then give, again, a moderate dose to the other lymph nodes in the region, but give a higher dose to the lymph node with that's showing up on the PET scan. So while these studies are not funded through the foundation, these studies have certainly been enabled through the support of the foundation, and just spend a minute talking about how that happens. So, if I want to do a study, and so in this case, this is one of our PET study. It's looking at a tracer called PSMA 1007. This is a very sort of high level list of all the things that need to be done to get the study open. And for me, this creates a big headache, and I don't know how to do a lot of these things because they involve engaging Health Canada and certain types of paperwork and things. So what you need to do these studies effectively is you need project managers and research associates who know all of the ins and outs of running these types of trials and know how to engage our ethics boards properly and regulatory boards like Health Canada properly. And so in our case, we're very fortunate to have had Catherine Hildebrand working with us for many years, and she's a PhD scientist with a tremendous amount of experience in new drug development and in running clinical trials. So she really has gained an enormous amount of experience with helping us launch these imaging trials. And it's her funding to support her is where the foundation has been able to help us strategically over the years to make sure we've been able to keep her engaged in supporting our research program. And then her expertise has leveraged all of these other grants, which have involved clinical trials and other types of research studies exploring these new types of imaging, particularly the PET scan imaging. And if you were to add up all of these, and these are multi-million-dollar grants or funding, and this, in terms of the return on investment, I would say this is at least 25 times leveraging in terms of the funding we get to support our research compared to what the foundation has put in. So, so this is an enormous benefit to us in terms of being able to develop these trials quickly and efficiently. So that's it for me. Thank you for listening. Thank you all for joining us, and I'll pass it over to Pam now.
Okay, thank you, Dr. Bauman. And just a quick reminder to all of you joining us, please enter any questions that you have down at the bottom of the screen in the Q&A box, and we will do our best to answer all of them live, actually at the end of all of the presentations today. So please feel free to go ahead and do that, and we will be doing everything live. Coming up next, we have Dr. Len Lute, and Dr. Lute is a professor at Western University in the departments of chemistry, oncology, and medical imaging. He's a senior oncology scientist at the London Regional Cancer Program, and his research seeks to discover cancer-targeting imaging agents and peptide drugs, leveraging our medicinal chemistry expertise. Dr. Lute is coming to us recorded and for the first time ever in one of these prostate cancer research tours from the Molecular Imaging Lab in the Gerald C. Bain Center for Translational Cancer Research at the London Regional Cancer Program. And Dr. Lute will be speaking to us about discovering theranostics, radiopharmaceuticals that both image and deliver therapeutic radiation.
Thank you, Pam. Welcome to the Molecular Imaging Labs here, and I'm glad you could join us. My name was stated as Dr. Len Lute, and come on in. This is the sort of office area for the people who work in the labs, and this is where they would be carrying out their sort of desk work when they're not working actively in the labs. And this door here, we can go into the actual research labs. So come on in. So this is what we call the anteroom, and it's the location where we bring in our supplies, our chemicals, the materials that we use in order to make our imaging agents and theranostics that I'm going to tell you about. This is also the place that we get our lab coats on and, just make sure that we're safe. So I'm going to just grab my lab coat here and get suited up before we head into the actual lab. So what I'm going to tell you about today are theranostics, and I should define that, I think, because it's probably not a word you've heard before. Theranostics is combining therapy with diagnostic, and so that's where the term theranostic comes from. And so this is where we are developing new radio-labeled agents, so they're radioactive materials that can target cancer. And if we use one isotope, which in today's case will be technetium, we have then something that can be used for imaging. So that's the diagnostic part. We can get an image and see where the tumors are. But if we switch the isotope to a different one, and it would be rhenium in this case, then we have something that is destructive. It's a therapeutic isotope. So when it goes to the tumors, it will actually then eradicate the tumor cells. So it's delivering radiation directly inside the body to where the tumor is located. So first we can image it, know that the compound is going to go to the correct place and in the right amount, and then we can actually deliver the therapeutic part in order to then get rid of that tumor. So that's what a theranostic is. And we'll head into the lab and take a look at the work that's being done today, and PhD student Priyanka, who is working with technetium in order to make one of these theranostic agents. So come on in, we'll head through here. You can see here we have our radiation signs because we do have isotope in this lab, since this is where we're doing this work. So if we head on through to the back here, we can see that Priyanka is working in this rather unique fume hood. So a fume hood, of course, making sure that any materials, chemicals and such that we don't want to come in contact with are being contained properly. And she's actually carrying out these reactions where she has lead shielding in front of her, since these are radioactive materials. And so these panels that you see in front are actually blocks of lead inside of them. And the glass that she can look through while she's working is leaded glass. So there's actually lead inside of that glass, believe it or not, that then make sure that the radiation is controlled. So she is taking technetium-99m, a radioactive material that's used in hospitals every day. It's routinely used for the purpose of imaging. It's used to image cardiac disease, cardiac function. It's used for bone scans. If someone says they're getting a bone scan, that's likely a technetium agent. And of course, we're also developing these agents then for cancer using that radioisotope. So the work that we do then to develop the theranostic agent is we need to design and create these compounds that will target cancer very specifically. And so she has to carry out that reaction to take the radioactive material, technetium on its own, and to be able to actually form that theranostic agent that has a portion that would be able to go to the cancer cells very specifically. And so ultimately then we'll be able to, bring that therapeutic material to those cancer cells and be able to eradicate the tumor then. So once she is finished with all of her sort of work in terms of the chemistry of making these agents, we do need to analyze these compounds. So we need to make sure that, we know that we've made the right material. We need to make sure that it's quite pure as well. And I should mention, you hear in the background sort of the dinging noise. I don't know if it's coming through well or not, but we have a Geiger counter out always so that we have an idea of how much radiation is sort of around us while we're working. And so if I hold that closer, it'll make a lot more noise because then we're not shielded as well. So we have ways to make sure that we operate very safely and are able to count the radiation as well. So as I say, once we've made the compounds, we need to check that they're pure. We need to make sure it's the right material. So we do an analysis on that. So if you wanted to come over here, we can take a look at this instrument. So over here we have an HPLC, so it's chromatography. Perhaps some of you remember if you were in labs where you separated spinach colors or something of the sort, or perhaps had children who did such a lab. The chromatography is a way to separate different compounds, and it allows us then to actually see if we made the correct material and to see how pure it is. So we can see up on the screen that there was a sample run, and you see a nice sort of single peak that came out, showing that that material was quite pure. There's a couple little other things in there, but it was quite pure. And so we can then from that know that we actually, made the desired material that we wanted. So that's sort of some of the steps of creating a theranostic agent. And the work that we do in the Baines Molecular Imaging Labs in terms of bringing in radioactive materials and creating these theranostic agents. So I hope you enjoyed this brief little tour, and thanks for joining us today.
Thank you, Dr. Lute. Our next presenter is Dr. Aaron Ward. Dr. Ward is a computer scientist and principal investigator in the Baines Imaging Research Laboratory. He and his team work on developing artificial intelligence technologies to help physicians better utilize information from medical imaging scanners and tissue images. The goal is to improve diagnosis and treatment selection tailored to each cancer patient. Dr. Ward is presenting from his office this afternoon, and he will be speaking to us about simulation studies and artificial intelligence.
Thanks very much, Pam, and thanks to all of you for taking the time to join us today. So I'm going to show you a little bit of the work that we've been doing around artificial intelligence for targeting prostate cancer treatment. So the work that I'm going to show you is primarily the work of a recent PhD student who graduated from our lab, Ryan Alfano, who's now moved on to a medical physics residency. And he was addressing the question around how we can target treatment to cancer that lives inside the prostate. Rather than treating the whole prostate itself, can we target treatment to a tumor within the prostate? And how can we best do that? So to give you a little bit of background here on how we typically treat cancer that's confined to the prostate, meaning cancer that has not spread to the rest of the body. So there's a lot of different sort of scenarios that could happen. So in one scenario, you have the situation where you've got cancer that's distributed more or less everywhere throughout the prostate. And in that case, typically what's done is a more of a whole prostate therapy. So that can take the form of surgery to remove the prostate, such as Dr. Chin would do, as you're going to hear from him later, or radiation to the whole prostate, such as Dr. Bauman would do, that you just heard from Dr. Bauman. So that's a whole prostate we call radical therapy. On the other end of the spectrum, you have the scenario where you either don't have a lot of cancer or the cancer is very low grade, very unlikely to spread. And in fact, prostate cancer in some of its forms can spread so slowly that the patient is likely to never actually die of that prostate cancer. And so to spare such patients the burden of side effects of treatment, they're put on active surveillance where the cancer is monitored frequently through time. And if the cancer does start to grow faster, then sort of treatment steps are taken. What we're focused on here is the scenario where you've got cancer. It needs treatment, but it's primarily confined to one area within the prostate. What we'd like to be able to do with that is to avoid the side effects of whole prostate therapy, but to use some form of lesion-directed therapy. And Dr. Bauman showed you this in his presentation, the idea that we could focus, for example, a radiation beam down to that spot and to be able to intensify the treatment to that particular area. So how can we enable this? So to be able to do this, a physician needs to be able to target that cancer. So what you're looking at here is a magnetic resonance image or MRI of the prostate. I'm just sort of tracing the prostate itself out here with my pointer. And on this image, a radiologist has identified two regions that are a little darker than they should be. This one here and this one here, both outlined in red, and said, okay, we should probably treat those two regions. Those would be the areas to apply sort of treatment intensification. And if we look at this sort of fairly simple, easy case, you might think, well, this isn't very hard. Find the dark spots, delineate them, and treat them. But we'll learn in a minute. It's actually quite a bit more complicated than this. And interpretation of prostate imaging by physicians, even very well-trained physicians, is quite difficult with MRI. And so what our goal was, Ryan's goal in his PhD research, was to be able to develop an artificial intelligence-based computing system that would help doctors to find prostate cancer on MRI, to help make those cancers more visible. The challenge in building a system like this is with current AI techniques, we train them based on examples. So it's like training a small child to recognize a car versus a truck. You would show the kid a car, say this is a car, show them a truck, say this one's a truck, and repeatedly, here's a car, here's a truck. Eventually, the child starts to learn the characteristics of cars and trucks and can identify a car or a truck that he or she hasn't seen before. And these AI systems that we build are trained in a similar fashion. We need lots of examples. So we need prostate MRI scans and correctly identified cancer throughout the prostate to train the system to be able to do that task. And so this turns out to be a bit of a challenge. I'll illustrate that with these three images here that are a specific kind of MRI called T2 weighted MRI that shows us anatomy. And these three pictures are the exact same slice of the exact same patient, with the regions of interest for cancer contoured by three different radiologists. And you can see that the three different radiologists don't all make the same calls. They're not all the same. And so if you were treated by this radiologist, you'd have different treatment than if you were treated with contours generated by this radiologist. This gets more complicated when you consider the fact that an MRI scanner can be tuned to produce different kinds of images that tell us different things about the cancer. So the T2 weighted image tells us about anatomy. A T1 weighted dynamic contrast enhanced image tells us where an injected dye or contrast agent is pooling within the prostate tissue, and where it kind of pools up, as you see these bright spots here, is likely to harbor cancer. And so you can see this is the same piece of anatomy from the same patient as on the left, just imaged with the MRI system tuned differently. And the radiologists make yet slightly different calls about where they would treat. And we have yet another form called an apparent diffusion coefficient map that tells us how much water can diffuse within the tissue. And that diffusivity goes down in areas of cancer where prostatic ducts and spaces get tightly packed with cancer cells. So we see dark spots in regions that could harbor cancer on an ADC map. And you can see again, this is the same slice of tissue. All of this is taking the same slice of tissue from the same patient, and you have all this variability in the calls of the radiologist as to where the cancer actually is. So it's going to be difficult to train an AI system to do this task if the truth that we have from our imaging and our radiologists is as variable as what we see. So what we turn to is a trial that was led by Doctors Chin and Bauman around a group of men who, prior to having their prostate surgically removed, we had this imaging done on them. So we got the images of the prostate before surgery, and then after surgery, the prostates were removed and stained and put under a microscope where the pathologist can zoom way in on this tissue, and I'll zoom in even again, and look at the individual cells in the tissue. And at that level of resolution, the pathologist can readily identify where the cancer actually is or was, and outline it for us on this type of, we call histopathology imaging. So we want to use this kind of image as our truth to train our AI systems and test our AI systems. This is where the cancer really actually was in the patient that you saw before, the primary lesion. And so we invested about 4 or 5 years work into the development of a tool for aligning those tissue images back to the pre-surgical MRI from which they were taken. That was the work of Dr. Gibson, who has since moved on to Siemens, published in a set of 4 papers that sort of illustrated the different stages of that big undertaking. But now that we have that, we have the where we can trace out, as you see here, the physician tracing out where the cancer is on histology and seeing exactly where that was on the MRI, and even on the different kinds of MRI that are taken by the system, tuned in the different ways here that you see. So this enables not only education, but it also enables us to build better AI tools. And so the way that we do this, the way Ryan did it, was now instead of using the radiologist contours on the MRI as our training and testing for our system, we actually use the true locations of the cancer from the histologic images that have been aligned back into the pre-surgical MRI space using the technique, the registration technique that Eli developed. And when we have this, we're then able to train the system with true locations of cancer that you see here in yellow, and with locations where we know there was no cancer, according to the pathologist, that we outlined for just a couple examples here in red. So again, this is like training the child car versus truck, and we know for sure that's a car, and we know for sure that's a truck. We know this is cancer, we know that's not cancer, because we've got this tissue-based reference standard to go on. Zooming this out a little bit to build in the rest of Ryan's pipeline, so we see where the AI piece fits. So what AI in this space basically does is it takes the image information that's within these contoured regions and uses computer program to turn that image information into numbers that we call features. So that's this feature extraction step, is extracting numeric features describing what the image looks like inside of those regions. It also goes through a feature selection step to pick the features that are most likely to be able to distinguish cancer from non-cancer. And once that's done, this is where the artificial intelligence happens, where we train what's called a machine learning classifier to be able to distinguish, based on the selected features, to distinguish the cancerous regions from the non-cancerous regions. And we do that with a set of data that we use to train it. Once it's trained, we then take another set of data that is never seen before, and we put it through the classifier and ask it to tell us, what is this region? Is it cancer or is it not? And we check how many times it's right and how many times it's wrong on images it's never seen. And that's how we ultimately come up with its performance results. So this is a fairly standard pipeline in machine learning based artificial intelligence for medical imaging. So briefly, how did the system do? So his prototype system did pretty well. We use an error metric called an area under the receiver operating characteristic curve, or AUC. And this is something that you've probably never seen before. So to define what this means, an AUC is basically reflects the probability that the classifier, if I gave it a cancerous region and a non-cancerous region and said, which one of these is more suspicious for cancer, The AUC is the probability that it would get that right. So it was the probability that it would pick the cancerous one and say that one's more suspicious. So in this case, the probability is up at 80%, which is encouraging for a prototype system to be able to do on its own. So here's an example where it's distinguishing an actual true cancer that you see here, and you can see it on the tissue image, from a same shaped region just below that looks an awful lot like cancer but isn't. And it was able to make that distinction and say that one really is cancer, and it was able to say that that one isn't, as an example. To give you a little bit more of a window to the inner workings of the system, and there's a lot we could talk about here, but this is just a little peek at kind of how it thinks, so to speak. One of the features that it extracted, that it utilized for this, was something called a difference average feature. And what a difference average feature essentially can do is to translate a region, how sort of soft and smooth and smudgy it looks, into a number. So this region here almost looks like you put down some charcoal and then rubbed it with your thumb. It's kind of smooth and smudgy to look at the texture. And this one has got kind of more sharper edges in it. It is a higher number. This is a lower number. And it's these kind of numerical differences of quantifying image texture that the classifier is using to correctly identify that smudgy look as cancer and this non-smudgy look as not cancer, for example. Last result that I'll show you, we found quite interesting. The prostate you can divide into zones. So here you've got the peripheral zone of the prostate, and that's this piece out here, kind of looks like a mustache on this image. With the rest we can call the central gland. And in the central gland is where radiologists have the hardest time finding cancer. Cancer and normal tissue look very similar in the central gland. And the system that Ryan developed is performing with an area under the curve of 0.95, with 1 being, ultimate high performance in that area where the radiologists need the most help. So we're quite encouraged by that result. So Ryan's just published this work. It's accepted for publication in an international journal last month. So I'm happy for him around that, and happy for us. So this is where we're at, is this really was the first AI-based system that could do this task of distinguishing cancer from non-cancer using this aligned histology approach to define the lesions in a very accurate way. And what we're working on now is adapting this technology to show the doctor a heat map of cancer probability throughout the gland that will allow the doctor to decide on what the best treatment options are, and possibly how to focus down radiation or other treatment modalities onto the lesions. So we've been supported by multiple affiliations and multiple funding agencies. And just as Dr. Bauman mentioned, donor support through the foundation has been extremely important to us. In the type of lab that I run, it's a bit of a different type of support, in that the funding agencies tend to be a little more sort of conservative in terms of funding that sort of next logical step in the research, which is important. What foundation funds have allowed us to do is to really take on more higher risk, higher reward, new directions that we can build from the ground up and develop that competency that we then take to the larger agencies to get that continuation of funding. So really good for sparking new ideas is where our donor funding has been of great help to us. I'm going to end with what is now an outdated picture of our lab when we could stand like this, and you see a picture of Ryan there. And I will stop there and turn it back over to Pam.
Thank you, Dr. Ward. Up next, we have Dr. Lucas Mendez and Dr. Douglas Hoover. Lucas Mendez is a radiation oncologist at the London Regional Cancer Program, and his research focus is prostate cancer treatment intensification and quality of life improvement. Dr. Hoover is a clinical medical physicist at the London Regional Cancer Program and an assistant professor at the University of Western Ontario. He is the physics lead for the high dose rate prostate brachytherapy program and has been awarded research funding support through the LHSC Academic Alignment Reinitiative. His research seeks to leverage the capabilities of artificial intelligence to improve brachytherapy patient outcomes through enhancements in plan quality and procedure efficiency. Drs. Mendez and Hoover are also recorded today, and they are coming to us from the minimally invasive surgical suite, where they will be speaking to brachytherapy trials and also offering a behind-the-scenes look at the minimally invasive surgical suite.
Lucas Mendez. I'm a radiation oncologist involved in the management of prostate cancers. Today I'll be speaking about prostate brachytherapy together with my physicist colleague, Dr. Douglas Hoover. So what is brachytherapy? Brachytherapy comes from the Greek. It means in close contact to. So basically, in the context of prostate brachytherapy, it means the sealed source is in close contact to the prostate. There are different techniques in prostate brachytherapy. Low-dose rate brachytherapy, also called seed brachytherapy, can be used by deploying radioactive seeds inside the prostate. Those seeds will stay in the prostate in the long run, and it'll give off radiation by decaying the radioactive material. Another technique is called high-dose rate brachytherapy, in which the radiation is given as a pulse in a few minutes. The source is just inside the prostate for a few minutes. Both of these techniques can be used in different clinical settings, including as a monotherapy, as a boost to external radiation, or in the salvage setting for patients that have cancer that have recurred inside the prostate. Typically, here in our cancer center, low-dose rate brachytherapy is given as a monotherapy, while high-dose rate brachytherapy is given as a boost to external radiation. In the salvage setting, we typically offer high-dose rate brachytherapy to offer men the chance of salvaging the cancer that has recurred in the prostate post external radiation. Besides the cutting-edge research projects that I just spoke to you about, our brachytherapy division team is also interested in capacitating a new generation of brachytherapists. Recently, we just activated our fellowship program, in which the selected trainee would be able to participate with us in multiple brachytherapy cases in both gynecology and prostate brachytherapy throughout the year. Moreover, recently we have been capable of securing some funds to develop and launch the first hands-on brachytherapy workshop in Canada. This workshop will likely be launched in 2024 and will be able to provide practical and hands-on experience for trainees in brachytherapy. So minutes ago, I just spoke about different clinical use of brachytherapy. Here in London Regional Cancer Program, we have developed different clinical trials involving each one of different settings. In the monotherapy setting, we have a study called the 5+ clinical trial, in which we implant the radioactive seeds inside the prostate in a way that we try to avoid those to compartments and structures that are responsible for erectile function, including the neurovascular bundle and the canal wall. This is a phase 1 feasibility study that is currently enrolling patients. In the setting of brachytherapy as a boost to external radiation, we have the pan-Canadian phase 2 randomized clinical trial. The HOPE trial is close to complete accrual and has enrolled close to 80 patients and is randomizing these patients between high-dose rate brachytherapy as a boost to external radiation, either as a normal fractionation external radiation in 25 fractions of treatment, or in the hypofractionation schema with only 5 fractions of treatment. This trial aims to investigate the role of brachytherapy in conjunction with the faster pace external beam radiotherapy delivery. The last trial that I'd like to speak to you about is called the ROADSTER trial. This trial has been developed to assess the role of high-dose rate brachytherapy in conjunction with experimental therapy called PSMA with lutetium-177 as a radioligand for patients with radiorecurrent prostate cancers. The rationale behind is that we know that 50% of the patients that have cancer that has recurred inside the prostate, they end up with cancer progressing elsewhere in the body. Thus, by providing early in the the natural history of the cancer, therapy with PSMA lutetium therapy, we may be able to reduce the chances of recurrent disease elsewhere in the body, outside the prostate. This study is a feasibility and safety study that is currently open and enrolling patients here in the Cancer Center. Hello, my name is Doug Hoover. I'm a medical physicist here at the London Regional Cancer Program. We're here in the OR where we perform our brachytherapy procedures, and I'd like to give you just a quick demonstration of how we actually perform this procedure. So, one of the tools that we use to get this radiation into the patient are these hollow needles. And in these needles, we're going to pass a radioactive source all the way inside. And in the case of low dose rate, this will be open at the tip here, and we can insert seeds permanently into the prostate. Or for high dose rate, the tip is closed, and we pass a high dose radiation or high activity source, and it pulls out at various positions in the needle. So the way we get this needle into the prostate is through image guidance. We use a transrectal ultrasound. The probe is shown here, and it can actually image in two planes. So we can image the patient this way. So that's essentially a cross-sectional image here, or we can image this way. That's a sagittal image. So using that, we can actually guide these needles into the prostate. And what we have here is what we call a phantom. It basically mimics the patient geometry. So you can see on the screen here. I put it to transverse view. So this is again the cross section of the prostate. The urethra is supposed to be mimicked by that black circle inside the center of that other circle you see there. So what we're going to do is we're actually going to put a needle into this prostate, and you're going to see it as a bright flash. You see that flash showing up? You can pull it out. That's the needle going in. And again, the needle is going into the ultrasound screen there. Now, if I switch views to the sagittal view here, it'll just take a second. Then I can advance. We can actually see, this is what we'd see in the procedure itself. We could watch as the physician advances the needle all the way to the base of the prostate. So that's what we do for one needle. We typically, for an HDR procedure, will advance 12 to 16 needles into the prostate. And after we position them all correctly, we will acquire a 3D image acquisition. And to do that, we will switch back to this axial view, and we will simply slowly pull the probe out, and you'll see the prostate coming into view there. And as we do this, we're acquiring all of these frames, and that allows us to actually build up a 3D representation of the patient. And that's how we do the radiation plan. One of the other developments that we're working on over the next few years is incorporating artificial intelligence, or AI, into the brachytherapy procedure. Now, there's many ways to do this. One of the tools we're looking at is to use it to automate some of the procedures, or some of the more time-consuming procedures, such as manually delineating prostate. So typically that will take 5 to 10 minutes for a physician to do, versus only a few seconds for our AI trained network. And if you think about it, the physician actually takes 10 plus years to be able to do this, versus our network, which we can actually train from nothing to being able to perform at the level of a radiation oncologist in a matter of a few hours. And from that point on, I can conquer in only a few seconds. So it's some pretty exciting developments that we're working on here. So on behalf of Dr. Mendez and myself, I just want to express my sincere gratitude to the London Health Sciences Foundation and the generous donors, because without you, none of this research would be possible. So thank you so much.
Thank you, Dr. Mendez and Dr. Hoover. And our next presenter is Dr. Ricardo Fernandez. Dr. Fernandez is a medical oncologist at the London Regional Cancer Program and an assistant professor within the Department of Oncology at Western University. He is the Fellowship Program Director for Medical Oncology. Dr. Fernandez's research interests include predictive biomarkers, the microbiome, pragmatic trials, and genitourinary malignancies. Dr. Fernandez is coming to us from his office this afternoon, and he will be speaking to personalized medicine in the treatment of prostate cancer.
Thank you, Pam. So my name is Ricardo Fernandez. I'm one of the medical oncologists here at the Cancer Center. And first of all, I would like to thank London Health Science Foundation for organizing this event. I think it's quite important. I would like to thank all of you donors or whoever you have done for the community. The work we do here, whether this is patient care or research, we wouldn't be able to do that without your support and help. So what I would like to talk today is a little bit about precision medicine prostate cancer. So the fact that I'm a medical oncologist, every time I see a patient is to discuss or any drug therapy. And I think I would like to highlight what we've been doing differently lately in regards to precision medicine. So this is my disclosure slide. I do not have any relevant disclosures for this presentation. So this is just a snapshot in terms of what types of treatments, what options we have to treat patients with prostate cancer. On the blue columns is basically each phase of the prostate cancer. So you see here localized prostate cancer, non-metastatic castration-sensitive prostate cancer, non-metastatic CRPC, which means castration-resistant prostate cancer, and then the two metastatic phases here. And on the light blue column, you can see the treatment options and the trial that has led to the approval of that treatment. So you can see here enzalutamide, docetaxel, so enzalutamide, abiraterone, and apalutamide, they are oral hormonal pills. Docetaxel, cabazitaxel are chemotherapy options. And then we have olaparib, rucaparib. There's oral target therapies for specific patients whose tumors harbor specific proteins. We have pembrolizumab, which is a immunotherapy drug. And then finally here, ipertarcetab, which is another oral target therapy drug that is given for patients whose tumors harbor another protein mutation. And then finally, the lutetium-177 PSMA that has been already mentioned here. So this is, again, just to give you a snapshot of treatments. Most of these treatments are available, are Health Canada approved. We have funding for those. Some of them are not. But essentially, what is precision medicine? Precision medicine, basically every patient is unique. In the evolving field of precision medicine tries to ensure the delivery of the right treatment to the right patient at the right time. So basically, and how do we best select treatment to a patient? So that's through precision medicine, also called personalized medicine. So essentially, this highlights the need for identifying what we call predictive biomarkers. So in precision medicine, patients with tumors that share the same genetic or molecular change receive the drug that targets that change, no matter what type of cancer. So that applies for any solid tumor. And the biomarker testing or predictive biomarker testing is a way to look for genes, proteins, mutations, other substances that can provide information about the cancer of that patient. Each person's cancer has unique patterns of some biomarkers. And there are some biomarkers that affect how certain cancers treatment work. So the biomarker testing is also called tumor testing, genomic testing, molecular testing. It's not genetic testing. Genetic testing is something different. But biomarker testing can be, trying to identify these predictive biomarkers can be done through blood work in some situations, or with the biopsy of the tumor that has been already removed, and then you analyze the molecular abnormalities within that tumor. So basically, this has been done in other cancer types, so lung cancer, melanoma, breast cancer, and more lately, now we have been doing that in prostate cancer. So I'm going to give you some examples here of some target therapy treatments based on the biomarker that the patient has that we can treat. So here on the right-handed side, here you can see like HRR mutations, which means homologous recombinant repair mutations. Some patients, the tumor does have a DNA repair deficiency gene or protein. And for these patients with this type of prostate cancer, we can use these PARP inhibitor drugs, which are oral target therapies. PTEN loss, it's another pathway, it's another protein or mutation that some tumors would have that. And then we have these AKT inhibitors, which are other oral hormonal pills. So just to talk a little bit more, the PARP inhibitors, this is just a picture here just to kind of describe a little bit better. But essentially, the patients who have metastatic castration-resistant prostate cancer who have progressed on enzalutamide or abiraterone, which are some of the standard of care oral hormonal pills that we use in these patients. We look for these specific proteins or mutations, BRCA1, BRCA2, or 8A mutations. And these treatments, if the patient has the type of mutation, when we apply this treatment with PARP inhibitors called olaparib or rucaparib, essentially the patients live longer and the cancer stays more, like we can control the cancer for a longer time. The same applies for, like I said before, the AKT inhibitors. This is the pathway, essentially, PI3K, AKT, and mTOR inhibitors. So once again, when the trial combined this drug, ipertacitab, which is oral target therapy drug, with another fancy oral hormonal pill that we've been using for years in these patients with metastatic castration-resistant prostate cancer, the same happened. Like these patients had the cancer control for a longer time and with better responses to the tumor. And finally, immunotherapy. Some of you may have heard about immunotherapy, which is essentially what we do here. We give some drugs. They are intravenous drugs. We have a few of them, pembrolizumab, nivolumab. But essentially what these drugs do, they activate or jack up the T cells, the immune system cells, to fight off the cancer. So they generate like an inflammation of the immune system. We have some of them, like they call CTLA4 inhibitor or PD-L1 inhibitors. And again, it would depend on the type of biomarker that cancer has. So patients with TMB, tumor mutational burden, hormonal recombinant repair genes, like I said before, PD-L1 expression, or others like MSI, DMMR. So essentially, if that tumor harbors these types of mutations, protein genes, we can treat these patients with immunotherapy, and the likelihood of responding would be much higher, right? So finally, talking about precision medicine, there is increased recognition of the overplay between microbiome and cancer. So essentially, what is microbiome? Microbiome is we have our gut bacteria. So this is called microbiome. So it's bacteria, microbes that we have in our gut. And essentially, everything we eat, our diet, whatever we eat, if we take medications, antibiotics, that could impact our gut microbiome in a positive way or in a negative way. The same happens with cancer treatment, chemo, immunocheckpoint inhibitors, which are the immunotherapy drugs, target therapies, hormonal treatments. Every time we give this to the patient, whatever the gut microbiome that patient has, the patient could have a better response, could have a less response. It could have more side effects. So we talk about the intratumoral microbiome. So there is a connection between the gut microbiome, the intratumor microbiome. So that has been really sort of top-notch these days about the microbiome and cancer crosstalk in terms of response to treatment, side effects, which we call toxicity, and whether or not the patient is going to live more or less, the survival, the longevity. So based on that, I've been doing a study called Intergut, INTEGUT, where it's a prospective study. So we are trying to see the association between the oral hormonal pills that I mentioned before, we call androgen receptor target therapies, these fancy oral hormonal pills, and the GI, the gastrointestinal microbiota in patients with prostate cancer. So we're trying to see the connection, the relationship between the effectiveness of these treatments and the side effects of these oral hormonal pills with the patients' associated GI microbiome communities, what we have in the bacteria that they have in the gut and the intestine as well. So this is a project that I've been collaborating with microbiology with Dr. Jeremy Burton and immunology, Dr. Saman Maleki from here. So this is just the study schema here. So we are aiming for 40 patients. It's a proof of principle study where we're trying to, again, establish the relationship between the gut microbiome of the patients and the use of these oral hormonal pills. So at baseline, we do stool collection, blood work, to try to establish the stool or the gut population of that patient. We do extra blood work to try to analyze the immune system changes. And of course, we collect clinical data. The patient starts on this ARAT, androgen receptor axis target therapy drugs, these fancy oral hormonal pills. And then we collect again stool, blood at 3 months, 6 months, and 9 months. And we will do a bunch of different tests to try to analyze the gut microbiota, the immune changes, and see what is the response to these treatments, if that affects the response, if there is any association between that and response and toxicity and side effects. So what I'm doing that, why did I say this is a proof of a principle study? So I've been quite successful in doing a study in kidney cancers. It's different than prostate, but it's a different type of cancer, where we treated patients undergoing immunotherapy, a different treatment, and we give these patients immunotherapy fecal microbiota transplantation. So we give like capsules, like kind of a probiotic type of capsules with stools from health donors. We give that to the patient with the aim to try to alter the gut microbiota of the patients undergoing immunotherapy to try to improve the efficacy and perhaps potentially decrease the side effects associated with these immunotherapy drugs. So this is a phase 1 study that we call like a very early stage, but that's the idea I have with the prostate cancer study. So that's the initial study that we try to establish that relation between the GI or the microbiota and the use of these drugs. For the future, we try to, at some way, alter the gut microbiota of these patients with prostate cancer with some sort of treatment. Whether this is going to be FMT, fecal microbiota transplantation, or probiotics or prebiotics, we will have to get more the data, but that's the goal at the end of the day of our microbiome and prostate cancer studies. Finally, this is my final slide. I just want to mention the fellowship, which is key for us to do research. So I'm the director of our medical oncology fellowship and also the supervisor for the GU fellowship, for the genitourinary malignancy fellowship. We had a former fellow, Dr. Jasna Delusi. With this fellow, we are aiming to provide opportunities in research, education, quality improvement, and translation research. Jasna, Dr. Lucy, had been involved in the study with kidney cancer patients with FMT. She's now gone for BC. She got a job there. She finished her fellowship. And essentially, it's myself, Dr. Maleki, that I mentioned before, immunologist, and our GU medical oncology group, Dr. Winquist, Dr. Ernest, and Dr. Potvin. I think that's my final slide. I will stop here and I will get back to Pam. And thank you very much for attention. I apologize for the technical issues I've had here, but I really thank you for attention.
Thank you, Dr. Fernandez. Appreciate that. And just again, because we will be concluding our tour shortly, so just a reminder to everybody to please write your questions in the Q&A box down at the bottom. We will be answering them live at the end. And I see Dr. Chin has joined us, and it is my pleasure. Hello, Dr. Chin. It is my pleasure to introduce our final speaker of the day. So Dr. Chin, who is coming to us from his office, Dr. Chin is a professor of urology and oncology at Western University, and he will be speaking to us about clinical trials.
Thanks very much, Pam. And I just want to welcome all the donors for all your help over the years. You know how important thing is in helping all the research that has been going on and all the research that is still to come. I'm going to talk about clinical trials. Actually, specifically, I'm going to concentrate on one particular technology. And it's on minimally invasive therapy for prostate cancer. Those of you who have joined us previously in some of these tours will have seen a couple of these previous slides, but I'll just go over them again. But I want to update you on the this particular technology. So first of all, minimally invasive procedures, you've heard that term before, is any medical or surgical procedure which uses smaller incisions than a traditional open incision to gain access to and to treat diseased organs. So some of you probably have had these procedures yourself, such as gallbladder removal, and this is a knee arthroscopic surgery, same thing, and the arteries can be dilated or can be opened up because of some narrowing in the arteries and close to the heart. This is just again showing the knee. Now in urology, we do a lot of minimally invasive surgeries. We take kidney stones out. We blast stones. We also take out kidneys altogether. And then, of course, now we're into prostate removal and also prostate therapies. So I just want to show you this picture here, this diagram, to show you the importance of imaging. Dr. Ballman has already talked about imaging, and we talked about MRI, we've talked about PET scans. So I want to talk about how important it is in terms of its relationship to some of the tools that are being used in treating prostate cancer. Dr. Mendez, Dr. Gruber had talked about brachytherapy earlier, but I want to concentrate mostly on TULSA, transurethral ultrasound ablation. But in the previous talk, I've talked about cryosurgery, that's freezing, and HIFU. I noticed that there's a question from the audience about HIFU. The answer is yes, we're still doing research on it. It works very well. It has a specific niche. There's certain patients it works well in certain indications. I won't be concentrating so much on that as this other transurethral ultrasound ablation, which actually, again, uses ultrasound. HIFU uses ultrasound as well. So just going back, just to repeat again, key aspects of minimally invasive procedures is either an external approach or a small incision. We need superior imaging for treatment guidance, as I just mentioned. We want to only create or minimize the amount of collateral damage, or no damage at all, if at all possible. So we have to have the ability to selectively target bad tissue but to spare the good innocent bystanders, basically. And then, of course, at the end, we want to see how well we worked, how well the cancer is treated, and we also want to document it and also validate the results. So this is back to the cryosurgery. You may notice the date up here is 1995. So we've been working on this for 20-some years now. This is cryosurgery when we first started. Just a quick rundown. We used ultrasound, and we actually had the good fortune of Aaron Fenster, who actually pioneered three-dimensional ultrasound. And I noticed there's a question earlier at what makes London a world leader in imaging. Well, this is the answer here. Dr. Fenster was the first person in the world actually to talk about who actually devised and designed three-dimensional ultrasound. And that technology is now used all over the world. This is one of my collaborators earlier, radiologist, and as you can see, there's a former prime minister visiting the lab here. So cryosurgery I won't get into, but we've been a leader in that along with Calgary, but we were the focus, our focus mainly was on people who have failed radiation treatments. And HIFU, again, there's only one slide on that. I've done HIFU on patients, again, people who have failed radiation and subsequently needed additional treatments. So, there's HIFU again, just to focus ultrasound in one spot, and we can treat the prostate here like that. Now, one other quick word on focal therapy. Prerequisites of so-called focal therapy, we're working within an organ, is that we want to accurately document the site, so a biopsy the site in 3 dimensions. I've already mentioned we have to exclude cancer in other locations, so they separate the good from the bad. And then we want to be effective and we treat safely or ablate safely the tissue, and we want to be able to get back to that same cancer focus after the biopsy to destroy it you also want to validate the treatment with follow-up biopsies, and then we monitor patients afterwards. So this is what I wanted to talk about, is the transurethral ultrasound ablation of the prostate. So this, as you can see, is an MRI unit. This is the instrument here, a special unit that couples with the MRI unit. This is the bladder over here, the prostate, and treatment is being rendered by these little ports, those little openings that shoots out energy, and this whole probe rotates, so it's in the middle of the prostate. You can see it like in a donut going through the hole, and then it rotates, and in the process it treats all around the whole donut. And we want to, of course, spare the rectal wall here. So here's again looking at this. So it's guided by MRI, magnetic resonance, and again we use high intensity ultrasound. So, but it's not HIFU. HIFU is more focused in one spot, whereas this actually uses kind of like a blade, almost like a sweeping maneuver that sweeps all around in the plane and it goes all around to treat. So there's real-time control based on MRI. Thermometry is the body heats, basically the heat map that we can sense and have feedback on the for the treatment. And then there's also cooling, since the rectum is here, you want to cool that, we don't want to cause any damage. So I won't get into the details here, but this is different components of the MRI along with the actual instrument, the applicator, and the robotic systems. So this is all like this. So just to show you what happens here, the patient is actually in an MRI unit. The probe goes in. The probe goes inside, and then we take MRI pictures. So 10 pictures, each one showing the target, the boundary of the prostate. So out here, just a smaller area, but up here is a bigger area, of course. And then we mark it out along all 10 spots, and then we treat, as you can see here, the different temperatures as it treats. The marker sweeps around and it treats the prostate this way. The beauty of this is that we can actually, when I mark the prostate, I can mark it. So if I want to treat a little more, a little less, I can do that. I can protect the rectum back here, and or if there's a little more cancer out here, I can actually again mark it out and treat it more here. So the whole idea is to try and protect as much of the surrounding good tissue as possible and treat the and just treat the bad tissue. Of course, as you can see here, we did the whole prostate, but we can also do so-called focal therapy, or just part of the prostate. So this is actually a team sport, but it is really a very well coordinated team. We need a lot of personnel. This is just outside the MRI unit before the actual treatment. We check everything, make sure everybody is on the same page in terms of what we're doing. The anesthesia people and the surgeon, myself, the radiologist, and of course the nursing staff. And so, but this is after we've already done a lot of homework and screening and making sure the patient is suitable. And then once inside the MRI unit, this is acquiring the images as you saw earlier, the initial imaging, and then we have to fine tune it. We make sure that everything is precise. We're down to really less than 1 millimeter in terms of the precision of the target and so forth. And so we do detailed planning. If everything's just aren't right, we do it all over again. So there's different maps here. And then the treatment is started. And there's a constant loop, basically. It's automatic and it's robotically driven. I can adjust it as we need in terms of fine tuning how much heat needs to be delivered and so forth. And then finally, confirmation of the treatments. So as you can see, this is an extremely elegant and very detailed process in terms of treating the prostate. Some of the work was done at the Robarts Institute in London. I should say that the original device was actually designed, the whole concept was designed at Sunnybrook, but we did some of the work here at Robarts. These are dogs. And then have the, I'm sorry, this, try and get rid of this. Some of the initial work was done here, and then we started a clinical trial, which, as you can see here, with the actual patient inside the unit. There's a lot of work going on there. The first trial in the world was collaboration amongst 3 groups in 3 countries, here at Western, a group in Heidelberg, Germany, and a group in at Royal Oak, Michigan in the US. So we actually did the very first case in the world. So the first trial was actually so-called safety and feasibility. And the goals were met in that we showed that this was a safe procedure, it's feasible. And then 5 years later, actually, sorry, 3 years later, we did a follow-up on these patients. It showed that, I won't go through the details, but it shows favorable results, were durable. There were no serious side effects, no serious incontinence, or other significant decrease in sexual function. Now, what actually, what actually shows here is that there is initially some decline in the function, but it actually improved back pretty well close to baseline. So this is one happy gentleman who happened to be in the first trial. Some of you know this so-called Mars building, medical and related science building in Toronto, just on College Street, intersecting with University Avenue. Well, actually, this is actually outside there. They actually show that there, and there's University Avenue right there. So this was actually one of the procedures that's also being researched, as I mentioned, at Sunnybrook, but at the Mars building, they actually had a lab there. So this whole program started in 2008. The first trial that I described to you was actually 2013, 14. So it took a number of years before we got to the very first patient. Again, we were fortunate to be the first to do it. And then they had some approval from the European Common Market. And then the FDA and Health Canada, this is the second study, so I'll just go over in a minute. So the first study we did was 30 patients. Second study is 115 patients in 15 centers, mostly in the US and then 2 in Canada, here at Western and London Health Science, and also at Sunnybrook. And then you can see there's progression here. I'll just go over the trial. The second trial, as I mentioned, 115 patients, 13 different sites. We actually had, again, more of our share of the patients, we had more than 10% of the patients. And it shows that the PSA, the blood tests, actually decreased by 95% and was stable at 3 years. So we didn't totally destroy every single bit of tissue as expected, because we actually had to leave a little rim there, but 95%, and it remained stable. And then there's extensive biopsies being taken, and 80% of patients show that there was significant improvement with no further cancer. And then 13% of patients actually had to undergo additional therapy. Now, prostate volume was actually significantly decreased in 91% of patients, from 37 cc's to 3 cc's, so it really shrank. Now, this is what I wanted to show. We actually showed that in the first program as well, but this is what was confirmed in the second trial, which showed that urinary leakage, and there was a little bit of a drop initially in the performance, but then it went back to baseline improvement in the 2 or 3 years. So same with erections, not 100% back, but back to 80-some% in the majority of the patients. So the whole process was basically very, very encouraging. And then we went on with some additional studies around the world. There are now new programs that we expanded the indications for this particular procedure, looking at different types of prostate cancer, the more aggressive ones as opposed to the less aggressive ones. We started with the less aggressive ones. I also mentioned that the prostate shrank a lot. So in fact, they're trying uh, in patients who just had so-called benign prostate enlargement and but no cancer. Now, this is the area that I've been working on for quite a number of years with the so-called cryosurgery, salvage, and HIFU. And I know Dr. Mendez and others, and Dr. Bauman have been working on brachytherapy for those who had failed radiation and then additional treatment. So this is another modality that's being applied now, is the salvage. But then with all this, there's still the $64,000 question, and that is TULSA as effective as the established treatments, such as surgical removal of the prostate? And can TULSA substitute or even supplant radical prostatectomy, that's the surgical removal? So to answer that, we're actually embarking on a new so-called randomized controlled trial. So as you can see here, patients will be randomized. This is the whole design, treatment group and a control group. And then of course they follow up and they eventually have results. So basically that's what it'll look like. One group will get TULSA, one group gets surgery. I just want to draw your attention to the fact that we're going to have 200 patients, 201 actually, but the ratio is 2-to-1, so that 2 patients out of 3 will get TULSA and 1 gets radical prostatectomy, and that's the design. You can see the number of trial sites here, and the primary endpoint is that we want to see, of course, it'll be safer and hopefully better in terms of incontinence and erectile function and so forth. So we want it to be superior, actually. So-called quality of life. We think eventually it will be better with TULSA than radical prostatectomy. And the other endpoint, the primary endpoint, is a so-called non-inferiority, meaning that it will be equal. And that is in terms of cancer control, we're hoping and targeting that this procedure will cancer control will be as good as radical prostatectomy, but with better quality of life overall. So eligibility criteria here, but so far we've been still the leading accrual site amongst all the centers. Of course, the results are still pending, but I just wanted to draw your attention to this, that we're working hard on this. So just finally back to the same slide, just to reiterate that we want to be sure that there's superior imaging, which we have with this MRI unit, a clear distinction between the diseased area and normal areas. We can sometimes see that on the MRI, actually, an ability to selectively target bad and the spirit of good, and we can document it and validate the results. Just want to show you that this is, they're kind of gone overboard with this in terms of this particular patient. This is in one of the meetings that you can see one of my colleagues somehow found this picture, the whole display here. And so with that, I'm just going to end here, and just to say that this is actually, we think TULSA, this particular technology and the trials that we're engaged in seem to be very promising. We're actually getting good results, and hopefully this will add further to the armamentarium of patients who are in need of treatment for prostate cancer. So I think I'll just end there, except also to say that as you saw, that this is fairly labor intensive and resource intensive type of research, and we really couldn't have done that without the help of generous donors through the foundation to fund the research nurse, we have to book, for example, the MRI unit and the time and so forth. So this is just an example of where the donor dollar has been going. And with that, I'll just end and just thank you again.
Thank you, Dr. Chin. And I'd like to welcome everybody, all of our clinicians and researchers back to the screen for questions and answers. So why don't we go ahead? We've got about 15, 20 minutes left. And so we've actually got quite a few questions to get through. Do prebiotics and or probiotics benefit a patient with prostate cancer?
That's a good question. I mean, that's why I've been doing this study for now. I mean, there is data, of course, like I said, that the gut microbiome is associated with modulation of immune function. But there is also data that there is a link between the gut microbiome with the use of other treatments, such as hormonal pills, chemotherapy. So we also know that the gut microbiome differs according to the lifestyle of a patient, diet, sex, race, genetic background, and country. So there is a connection, certainly between the gut microbiome and prostate cancer. We know that high-fat diet can cause gut dysbiosis and gut bacterial metabolites, and that may affect the systemic circulation and the androgen deprivation therapy. But I cannot, at this point in time, we do not know if probiotics or prebiotics would have either negative or positive impact on the treatment outcomes on cancer, whether this is a risk factor or if that's better. Definitely lifestyle modification can improve the gut microbiome and some specific bacteria. That's why we're doing this study, because we know that some specific gut bacteria population may have better response to treatment. Some may have less good response to treatment. There is also a link between some specific bacteria with toxicity, with side effects. So that's why we're doing this study. But to answer the question, we do not know, we don't have any data at the moment that probiotic or prebiotic can cause or can improve prostate cancer outcomes or treatment.
Okay, great. Thank you, Dr. Fernandez. Our next question is, how many compounds do you create in a lab in a year?
That sounds like that one's for me. All right. So yeah, that's a great question. So, when you do this sort of trying to discover new compounds, relevant and very specific for a cancer, starting the lab, we're probably for a target be making anywhere from 10 to 100 different compounds that we're evaluating, sort of cell-based assays and such, to try to find new agents. And it's really like a funnel. You can think of it as a funnel that we go from hundreds down to sort of the best ones that do seem very selective for the cancer, for the target we're after. And then we'll do that radiochemistry that Priyanka was doing in the lab and make it radioactive. Once we've got that developed, we sort of move down to the best one going into an animal model to see if this works actually in a living system. And then you hope after that you'll have something that you can bring through and bring into a human. So that's sort of the approach that we take and the kind of numbers of compounds that we work with.
Okay, thank you. And I think this next one is going to be for you as well, but it's, will theranostics be used to treat all cancers or just specific cancers?
Another great question, because there is a theranostic compound that's been used probably a decade now for neuroendocrine tumors. So conceptually, it's been around and it's been shown to be very effective. But that's just for certain carcinoids and insulinoma, certain pancreatic cancer. It's fairly limited, the one that was available up until recently. But what's exciting is what Dr. Baumann alluded to, these PSMA agents that are coming along for prostate cancer. And so there is theranostics in clinical trials, for prostate cancer. And that works for many, potentially for many patients, but there's some that it will not work for because of that target. And so, we're continuing to search then for very specific agents for other targets for prostate cancer. We're working on a chemokine receptor. FAPI is a fibroblast activation protein that we're making agents for. So I think there's a lot of work to do there yet, but I see increasingly that the theranostic approach is something that it's looking very promising. London has amazing connections for getting these special isotopes with our links to Triumph, the big isotope generating facility out in Vancouver, and that we're very closely tied in with them. In fact, just yesterday, a $24 million grant went in that we're a part of here with Triumph to bring these isotopes on board. So I think there's excitement, and I think we'll see it continue to really reach in for prostate cancer in particular over the next few years.
Wonderful. Thank you very much, Dr. Lute. The next question is, what the question is, I think this is going to be you, Dr. Bauman. When will you expect results from the Argos trial?
So we started enrolling men onto the trial as of this spring, and as of now we have about a dozen men enrolled, and our partner institution in Toronto has just started enrolling men. We're looking to enroll 50 men in total, 50. So we've anticipated that will take us somewhere between 18 and 24 months. Might be less than that. And then for our main question that we're asking, which is the safety of this approach, we need to follow these men for at least 6 months. So I think we're looking at least a couple of years down the road till we have that particular question, some information about that, and then probably more like 5 years down the road before we have questions about when we start looking at some of the questions about imaging over the longer term and how do men do in the longer run. But I think we'll have some results relatively quickly as to the safety of this approach. And while it may seem like a long time, that time goes by quickly. And in a cancer like prostate cancer, that's actually a fairly short time to get some answers.
Great. Thank you, Dr. Bauman. The next questions are around TULSA. So I believe, Dr. Chin, this will be you. Who are good candidates for TULSA, one? And the second is, will TULSA be provincially funded?
Yeah, those are good questions. Who would be eligible? We hope eventually it'll be patients who are actually currently being slated for surgery or radiation treatments. But these will have to be people who are determined to be free of metastases, so that the cancer hasn't spread. It should be still quite localized to the prostate and not too far out away from the prostate, because we can't encroach on the areas that are too close, such as the rectum and some of the other structures. So basically, the patients have to be so-called localized cancer, and that's what some of these trials are for, is to determine who would be the best candidates, like what stage the cancer should be, and also what grade. Now, if the patients have very, very aggressive cancers, then they probably are not good candidates either, because they will be more likely to have already have microscopic spread somewhere. The other question is, will it be funded? That will have to be determined. I don't think it will be for a long time, just because it will take a while before we establish the equivalence in the results. One other thing, the patients need to be eligible to go into an MRI machine. They can't have any metal that in the body that will be in danger when they go in through an MRI machine.
Okay, great. Thank you, Dr. Chin. During brachytherapy and ablation, is the patient put out or awake with freezing or other type of numbing?
I can answer that. I mean, for brachytherapy procedures, men are under a general anesthetic, so they are fully asleep for those procedures. There is the ability to do them under a spinal anesthetic. And for some of the techniques we use, we'll actually use a local anesthetic if we're just putting in some marker seeds or such. But for the brachytherapy procedures that were described, those would be done under a general anesthetic.
Okay, great. Thank you. I think we've got time for maybe our final 3 questions. How often do new drugs come out for the treatment of prostate cancer? And I think that might be you, Dr. Fernandez.
Yeah, I think so too. I mean, that's a good question. That's a tough question to answer, to be honest with you, because it doesn't really depend on us only. I'm assuming the question is, how long does the drugs take to get approved and everything else, right? Like available to be used in clinical practice. It's a huge process, like a clinical trial from phase 1 to phase 3 to develop a drug. It's expensive. So research is expensive. It usually take between 10 to 12 years from a compound that is discovered until it reaches phase 3 and it shows like survival benefit and we can use in clinical practice. And then it comes after that, of course, it's a discussion about price and whether or not it should be funded in a public healthcare system like in Canada. So I would say from phase 1 to phase 3, from the development of the drug until it gets to phase 3 and shows survive like a longevity survival like benefit, 10 to 12 years in total.
Okay, great. Thank you very much, Dr. Fernandez. And I'll throw this out there for any of you that would like to answer. Do you think eventually cancer will become a managed disease like diabetes, and it will allow people to live longer and, continued productive lives?
I mean, I'm happy to hear other people's thought and perception. I think you're right. In some specific disease sites, probably prostate cancer would be one of those. We are already there. Which is good. We have lots of treatment options. We can sequence them, like I showed you, like the first snapshot I showed you. We have lots of treatment options. Patients are living longer, living better. So to some extent, it depends on the definition of chronic disease, but it has become very treatable. People are living longer. Hence why we do need to evolve and create more space, and of course the healthcare would need to devote a little bit more financial support for cancer in the long run because of that, right? But happy to hear the people's thoughts.
So I think it's already treated as a chronic disease in some areas of prostate cancer. For example, the low-grade cancer that you won't even see. I see, and I don't know if Dr. Bauman may see some, but we see a lot of patients that have very, very low grade, very slow growing, small cancers. They actually are just being monitored and are not treated actively. We do subsequent biopsies to make sure that the cancer hasn't progressed or hasn't become more aggressive and so forth. So, but there's a fairly significant percentage of patients who are on the so-called active surveillance, and essentially they're being managed as a chronic disease.
Okay, our final 2 questions then. Will artificial intelligence continue to play a significant role in cancer diagnosis and treatment?
I guess that one's probably for me. I would say that artificial intelligence is only just getting started in playing a role in this area. In fact, the number of innovations in AI for medicine that have been published versus the number of such innovations that have actually made it into clinical practice, the ratio is huge. The big issue is crossing that translational gap from bench to bedside, getting these things into practice. So I think that we're going to see a lot more of this than we have now over the coming 5 to 10 years.
Okay, great. Thank you, Dr. Ward. And then our final question, and again, for any of you, what is the greatest need right now for cancer research? And how can donors help support what you're doing?
I can start if you like, but I really imagine that everyone, all of the physicians and scientists here have their own take on it. So hopefully you'll let a few people take a turn. From my perspective, our research team, there's grants available for running research projects. There's grants available for buying equipment, which is great. But we struggle with just maintaining equipment and keeping things functioning. And there really is, from the research side, it's very difficult to get the funds for that. So that's something that we struggle with, and that could relate to donors. But I know others have other things. So please say your piece as well.
Yeah, I guess I would echo that. I think a lot of the funding opportunities that are available through organization or other organizations do tend to focus on new things and new equipment and things and specific new research ideas, whereas really a pressing need is to keep a strong base both in people and equipment to let you explore these new ideas. You have to be able to support and help the existing group of clinical and basic scientists, continue to provide a stable environment for that work to happen, and so people can start to ask those next level questions. And I think also funding that encourages and helps these groups to come together and work together so that we can move discoveries from sort of the basic science benchtop venue or the computer venue into clinical practice. That sort of research sometimes and efforts sometimes falls into a bit of a gap in terms of funding, and I think that is always useful to have support to help us work together better.
Okay.
So I might just add, I guess on behalf of the clinicians, so Dr. Bauman, Dr. Fernandez, Dr. Mendez, that a lot of the work that we do really have to rely on our research colleagues in the science, in basic sciences and the translational sciences and other areas that, of course, we have clinical duties. And so the most important, probably the most valuable commodity is actually time. So we can, if there's support for a clinician to be able to actually get away from the clinical duties, a third of the time, half the time, or whatever, then they can devote that time to working with our other colleagues. That would be a tremendous help, I think. And of course, that needs support for that.
I would agree with Dr. Chin on that. Having clinician scientist partners who have that protected time is extremely important and valuable to those of us who, like myself, who are technology and tool developers, where we absolutely need the engagement of our clinical partners to understand where the gaps are in clinical workflow. What are the problems that really need solving? They're really going to matter. The other thing I would add from an AI perspective, AI research perspective, the big thing that our big commodity is data. And if you think about the amount of data that flows through the hospital in terms of images, tissue sections, diagnosis information, follow-up information, endpoint information, all of that kind of thing. To do what we do it effectively, we need those data points all collected together into curated databases, very clean databases to train and test our AI systems. So currently that's not something that happens automatically in hospital information systems. Things are kind of scattered, they're disparate in different systems. And sometimes follow-up information is not necessarily even through the hospital, it could be in the community. And so to move AI forward in this space, we need to take steps to bring all those disparate pieces of data, which are really like gold to us, together into uniform curated databases that we can use. And we've actually had support, donor support through the foundation. We've been able to hire one staff member who has been able to devote 100% of her time to doing this work. At this point, it's kind of by hand. but what a difference this has made for us in the past year and a half. And we really need to continue to build on that and accelerate it and bring in automated solutions for this in order for us to keep moving forward. So for me, that would be the big one.
Great. Thank you.
Yeah, I mean, I agree with everything that has been said here to answer the question. I mean, there's a lot of unmet needs and challenges. I think what I would like to add is the fact that donors can help not only providing financial support. You know, it's especially these days with the economy not doing well, not everybody would be able to help with financial, like with money, with funds. But also, I think it's also important, I'm a clinical trialist, and I find very important these days, especially when you look for grants, having patients engaged in the clinical trial development since the beginning. I think that's quite key, because we would get the perception, the perception from the patient, what we need to look for in a clinical trial, right? Sometimes what I think it's important may not be important for the patient with prostate cancer. So I think I would add that donors could help us, yes, providing, of course, money for infrastructure, for our research assistants. I mean, we are in the front, myself, Dr. Chin, Dr. Baum, and other colleagues here, but we have all the behind the scenes people, like the clinical research assistants, the data people analyze the data, the research coordinators. So, but I think donors being engaged in the clinical trial development, that would be very helpful.
Great. All right. Anything else? Okay. Well, thank you all so much. So this does conclude our tour, and we hope that you found this new information informative and helpful. And as you can see, there is some incredible research and work happening right here in London, Ontario. I'd like to thank, first of all, our presenters, our clinicians and researchers. Thank you for taking the time to share your work and to share your research with us. I'd like to thank our donors, because without you, this work would not be possible. And last of all, I would like to thank again all of you for taking the time out of your day for joining us this afternoon. Wishing you all a wonderful evening, and thank you.